Dave, welcome to our chat. Really excited to have a proper conversation with you about so many things. You're probably not a hugely familiar face to a British audience, what with you being a US allergist. What many of the people who follow me on Instagram won't know is that you are the allergy hero to so many of us allergists because of the work you've done on social media. But maybe the best place to start is, can you just tell us who you are, a bit about yourself, what your day job is, and we'll go from there.
Yeah, well, thank you for inviting me, and hi everybody. It's a privilege to chat with you today. So I'm Dave Stukus. I'm a professor of clinical pediatrics. I work at Nationwide Children's Hospital in Columbus, Ohio, where I serve as the director of our food allergy treatment center. So all I do all day is pediatric food allergy. That involves taking care of patients and oral food challenges and research and all that fun stuff. And then I'm an academician through and through. So in addition to seeing patients, I publish, not as much as I should, but on a somewhat regular basis. I've written a couple of textbooks, and I'm very involved in our organizations. I'm the current vice president of the American College of Allergy, Asthma, and Immunology, and I also serve on the executive committee for allergy and immunology within the American Academy of Pediatrics. So, lots of stuff to keep me busy. And then I've been using social media as a medical professional for about, oh my gosh, 13 years, I think, as a way to try to put good evidence-based information and perspective out in the world. Because as you know, and everybody watching knows, there's a whole lot of nonsense out there, and it is not getting any better, unfortunately.
Absolutely. And there's so many bits of your many faceted job that I would like to chat about. But let's start with the social media stuff. And you were a really early adopter. So when X was Twitter, you were certainly the first allergy guy that I was aware of that was on there with any sort of meaningful presence. How did you get into that? What sort of drove you onto Twitter?
I was doing some research on allergy misconceptions, which I think we'll probably talk about as we should. And just, I was just wondering, why are we getting all these referrals for things that were sort of put to rest a decade ago? And then I did some research surrounding that, did some presentations at some national meetings on that topic. And then my brother-in-law said, Dave, you should really go on Twitter with these messages. And I said, what the heck is Twitter? And so then I looked into it and I said, oh, okay, maybe this seems like a good platform to try to engage with the world. And that's when Allergy Kids Doc was born. And then I left that platform probably, oh my gosh, a year and a half, 2 years ago. I still have my account there, but it's just, the algorithm's all different. It's not a good place to engage. And I mostly use Instagram these days.
So how was it initially received? Did you get good feedback? Were people positive? Did you get a lot of trolls? Were you getting any sort of abuse? What was going on?
Yeah, it was mostly good, a little bit of bad. The trolls, so all the anti-vaccine disinformation, it's not new. This has been there for decades. It adapts to whatever platform there is. So they would come after me pretty hard. Surprisingly, the wellness industry and all those wellness influencers, when you try to debunk their supplements and say that they don't boost your immune system and why that's a bad thing if they could, they get really mad because you're approaching their bottom line and you're taking money out of their pocket. So I've been the victim of like well coordinated 24, 48-hour attacks. They've called my employer to try to get me fired. I have a voicemail from my division chief from a lovely woman in the United Kingdom, actually, who left a 5-minute rambling message about how I was wrong and that toxic mold is a major issue. So it's mostly good, but a little bit of bad.
Wow. And do you think that's evolved over time? Do things get sort of more coordinated against you? Were there sort of, do you get more of a sense that the pushback was becoming a little bit more sophisticated?
Yeah, like these concepts of like doxing where people will post
Yeah.
your public information and stuff. There's some nasty folks out there that take advantage of these platforms and what they can do. So yeah, it's changed, it's evolved. But there's
Yeah.
ways to deal with it, and it hasn't kept me from engaging. Mostly, you just ignore it and block people, but other than that, just don't engage.
And was that reasonably balanced with positive stuff? I mean, I found that since I've been doing this, that I get loads of people coming into clinics saying that they've really appreciated somebody putting stuff out there without any agenda behind it, which is very much what I've been trying to do. Do you think that's when most people see what was going on was landing?
Yes, I do, and it is like it's so heartwarming. And complete strangers will send me messages and thank you so much for this information. I had no idea I was going down the wrong path. I get a lot of folks asking me if I can help them. Unfortunately, I'm not licensed in wherever they are, but I'll always do my best to try to direct them towards reputable folks in their area. And then my own patients, I get a lot of patients just find me online, and then they want to come see me if they're nearby. So yeah, I agree with you. It's been very heartwarming, and that's what keeps me going.
Yeah, there's a slightly, if I'm allowed to say, it, slightly selfish angle to it as well for me that you can only have the same conversation so many times, uh, and and putting out there the stuff that you find that you're having to talk about again and again and again and again, it can be really helpful to just be able to direct people to something where you've actually had a bit of a chance to think about it. And I think the best example of that for me was, and I don't know whether this was a thing in the US, but the MMR and egg allergy,
Oh
and
yeah.
this whole idea that that seemed to be driven actually mainly by doctors who, when people with an egg allergy would show up and they were due to get their routine MMR vaccine, that the clinic nurse or the doctor was saying, "Well, you can't do that. You'll be allergic to it. You need to have it in hospital." And we sort of laid it to bed completely in about, I think, 2012. Put guidance out, changed the national guidance, all the official channels, and years later, we were still getting people that were just being sent away saying, "No, not safe enough." Was that a thing with you guys as well?
Yeah, mostly more influenza vaccination. The
Okay.
MMR, I always quote, I think it was the New England Journal of Medicine, they did the study like 40 or 50 years ago showing that MMR was safe in people with egg allergy. Yeah, but no, it's more the flu shot that people still to this day either ask about egg allergy or refuse to administer it, which is ridiculous.
So you've really focused on myth busting, which seems a very sensible place to be doing this. What are the big ones in the US that cause the most difficulty for patients?
This concept, this myth of a hypoallergenic dog, do you all deal with that in your neck of the woods?
We yeah we are a nation of dog lovers,
Yeah.
and I do hear this continuously about the cats and the dogs.
hmm
So what's your take on that? How do you sort of break the news to people that it's not really a thing?
Yeah, well, so right, it's a marketing term often used to increase the price for certain breeds. But the dander that causes allergy symptoms is present in the saliva, the skin cells, and in the urine. So, it has nothing to do with hair length or shedding or anything like that. And then I always followed up with, here's the good news. As an allergist, I've never once told a family to get rid of their pet. Like we can find ways to make it so that you can be near these animals that you love and treat your symptoms.
Yeah, no, we've definitely got that one as well. I think the one that comes up the most, or at least the one that I think causes the most damage to people's quality of life, is this idea that each time you react, it's going to get worse. And I remember once, and this is really not like me, but actually contacting one of the big TV studios who had put a TV doctor on, so somebody very reputable, who had just said this on telly and said, each time, you've got to be really careful because the next time you react, it will be worse than the previous one. And sort of has a little bit of a double take of did she really just say that on national TV? And in fairness, she was great about it. It was retracted. They did a whole section on allergies to talk about it to pull it back. But do you have that one as well?
Yes, and I hear that enough, and I always try to correct it just like you did, and that's admirable. But I say reactions can be less severe as well, and we've learned so much about all of the different factors that can influence how severe a reaction is. And when you say that this time it was just mild, but next time it could be life-threatening, the message that people hear is that you or your child, you're a ticking time bomb. And you're just waiting for that terrible outcome to occur, and it's a terrible way to live. And we know that's simply not true. It's not the case.
No, absolutely. And in a way, that's sort of an easy one to correct because you can give a relatively unnuanced but absolutely scientific view that these reactions are unpredictable. They're not going to get necessarily worse. Are there some areas that you found really difficult to cover? I think the one I found really challenging was around allergy on aeroplanes and managing that. Um, are there areas that you found really difficult to cover because it's difficult to be nuanced on social media? I mean, Instagram is certainly a lot better than Twitter, but certainly in one tweet, you're never going to get much nuance in. But yeah, how have you found dealing with those areas?
I learned a lesson years ago when we try to provide reassurance surrounding food allergy fatalities. That's very nuanced, right? And that's
Yeah.
really hard to do on social media, particularly when there are people out there that have lost their children
Yeah.
to a severe reaction to a food allergy, and that they have accounts and they're following you. And if you try to provide overall reassuring messaging, there's somebody out there that is going to, be triggered by it or take it the wrong way. And that's the last thing we want to do, right? We want to provide really good information, but we want to reassure people. But at the same time, there's somebody out there that is going to receive the message in a way we don't want them to. And so that's really hard to sort of talk about on that platform. I don't know if you've found a way to do so successfully or not.
I mean, I find that's one I find particularly difficult around fatalities, and I think one of the real challenges there is you've almost got a tension between charities who, for very, very good reasons, are not talking up the numbers, but they want to focus and highlight the fact that these reactions can be catastrophic, and consequently, it's absolutely reasonable to make demands of society, of government policy, to adapt to help manage the risk and to help people feel better about, make them feel safer, completely reasonable. But it's hard to do that without raising anxiety amongst people who, on an individual level, their risk is very, very small. And then as specialists, we're in clinic trying to say to people, look, yes, you've got to be careful because there is a risk, but you really can live your life and eat out and travel and go on planes. It is doable as long as you're sensible to all of this. There is a tension there between those two things. And I'm not sure how to get that right, and I don't know whether we do get it right. And I think for a lot of families, they find that very, very challenging. Well, they must do, because some of the stories I hear of families, how they live their lives, I've always found this fascinating. The enormous breadth of difference between how different families manage an identical problem. And there's clearly cultural differences. You find that families from different parts of the world will address it differently. There's clearly a very big age difference. I mean, goodness, if you leave any allergic child with their grandparents, God help them, because we we know it generally won't end well. But that whole difference, the way that people approach risk, etc. And I think there's a perception in the UK that in the US you do all of this much better, or do you think you see just as much diversity in the way things are managed? And do you think it's better because you've got a lot more allergists? I think there's maybe better access to allergy clinics. Do you think that makes much of a difference?
No, I think I don't know how we compare if it's worse or not, but no, we see a tremendous range, and the fact that anxiety plays such a major role in the lives of these families on a daily basis. There's really sad stories of people not sending their children to school, or never going to a restaurant, or never traveling, just because they think it's not safe. And we have to try to put it in context. And one way we can go into that is we talk about these extremely tragic occurrences, thankfully, are very rare, and we've learned that it's not happening to young school-age children, right? It's almost universally going to be adolescents and young adults, and typically it's when either they don't have their epinephrine with them, or maybe they don't receive it in a timely fashion. So when it does occur, very rarely, those are typically the scenarios that it's occurring in. So just reassure families, especially with their school-age children and babies, that they're not the ones that we worry about when it comes to this.
No, absolutely, absolutely. So, just thinking about your day job, not the social media, the actual seeing the kids all day with food allergy. How much have things changed for you over the last 10 years? I mean, for us, I think in the UK, I think the question would be how much have things changed in the last 5 years. I think this is the revolution is sort of a little bit more recent, but I think for you guys, it's been going on for longer.
In the way we manage food
Yeah, and the
allergy.
way you manage food allergy, actually being able to offer something beyond avoid it and see you next year.
Yeah, I mean, now, what I'm doing on a daily basis, and I'm sure you are as well, is I'm really phenotyping and talking about each individual's personal allergy. There is no one size fits all. It's, well, how allergic is this person? What's their individual threshold? What precautions do they need to take? What's their risk? And I think we have the ability to do that. And just, being as proactive as we possibly can to get food into the diet. If it's a child with egg and milk allergy, we're trying to introduce baked egg and baked milk. We're talking about using milk and egg ladders to try to, get less extensively heated forms of it in their diet, just to make it more manageable. Counseling people that the vast majority of precautionary labels are not going to provoke a reaction, because we know that most people with a peanut allergy, for instance, aren't going to react until they eat almost an entire peanut. So we can incorporate all of these things into the counseling that we offer. And then just therapy, with oral immunotherapy. Some folks are doing sublingual immunotherapy. We have omalizumab to actually treat people. And then with alternate, epinephrine devices, we had the nasal spray. And then the FDA just announced today that the sublingual form of epinephrine will hopefully be available this time next year. So, my gosh, it'll make your head spin just trying to keep up with all the changes.
It does, doesn't it?
Yeah, it's great.
And it's so fantastic. I mean, I remember when I started, and it felt like I was just doing diagnosis, because we just didn't really treat anybody with food allergy. And it's sort of almost gone to the other extreme, in as much as there's so many different therapeutic options, but it needs to be so personalized. And I think one of the biggest challenges I've found is, how do you find the time and capacity for managing all of those different options? Because it used to be, and we have the same time slots as we used to. It used to be, you just have to say avoid it, and there wasn't too much to talk about relatively. And now things are, we've been talking about personalized medicine for so many years, and finally it does feel like this has genuinely landed, and we're doing it, and it's brilliant. I mean, it's so what we trained and wanted to be doing, but it comes with its own challenges. And for me, the shared decision making is so the way that you want to be practicing, but how do you manage that in terms of maintaining, the huge number of patients that you've got to see?
So and the other thing too is with different levels of understanding of the patients that we see, right? So everybody learns and incorporates information differently. It's obviously a lot of practice, so you have to, have your spiel down to try to cut to the chase. I came up with, handouts to give people, and I typically tell them, I was like, listen, we're going to cover a lot of territory. I expect you to forget everything from this conversation. I'm going to give you a handout that covers everything again, and then I make myself available for follow-up. So, we have electronic messaging that we can do on the computer system that we use, and I say, please, if you come across anything, if you have questions about this, send me a question. I'll get back to you that day, unless I'm out of town. And I think that's been very helpful. But you're right, it's that those sorts of conversations and the way we spend our time, you have to balance that with all the pressures we have in medicine to see as many patients as we possibly can, and to bill for it, and to make money for our institutions. So it's just a constant struggle, right?
I mean, one of the things I was really liking about the developments in food allergy over the last few years was how, because there were new treatments coming out, it was a great opportunity for British allergists to work with Canadians, Americans who were just that little bit ahead of us and just had better access to these sorts of treatments to really get their support and experience at bringing in new treatments. And then omalizumab has come along, and it's such a different way of dealing with things, and it's one that really is going to be very challenging in a UK setting, where we've got a state-run health service where there's not really a scenario that an expensive biologic that you just stay on for good. Mm-hmm. And for people listening, omalizumab is this injectable medication. It got its license a couple of years ago now in the US, where regular injections generally make you much less sensitive to all the different foods. So, if you've got multiple food allergy, OIT wasn't necessarily particularly practical. I can see how it could be life-changing, but it's really expensive. And if it's covered by insurance in the US, you can get it, and you either have to be, very wealthy in a UK setting to be able to stay on it for good, maybe short-term to do alongside immunotherapy. But for me, the worry is that, are we going to see a divergence now between US medicine and UK medicine because we just aren't able to do the same things? Or do you think omalizumab is just going to stay as one of the range of options alongside everything else and not quite have that impact?
Yeah, it's interesting, here with the experience we've had over the last year plus. Some families, it's an automatic no. We don't want to do that because they don't want to give an injection to their child. Cost is an issue, especially if insurance doesn't cover it, or they just don't see the need to do that. It's interesting because you can find the optimal patient. So omalizumab treats multiple conditions. So if you have somebody with poorly controlled asthma, especially allergic asthma, if they have environmental allergies and food allergies, we're treating the whole patient now. So we're just going to make them feel better and protect them from having, anaphylaxis from accidental ingestion. So that's sort of a no-brainer for some of these people. If you have a child with one food allergy that they could potentially outgrow in the next couple of years, probably not the optimal treatment for them, for one reason or another. So yeah, it really is trying to find, who's a good patient for it. But you also have to be able to offer it to people and have that conversation about what to expect as well.
Yeah, and I think that's what's nice, knowing that sublingual immunotherapy is becoming more of a thing for food allergy. We've got epicutaneous to look forward to. It's having that range of things, I think, that will just, because as you said, every patient's different and everyone's got different expectations and priorities, and it's great that we're going to have those choices. And what do you think this is going to look like in 5 to 10 years' time? I think
Yeah.
I'm guessing you're probably like me, are probably thinking retirement. Um, but but how different do you think? Because practice is so different to 10 years ago.
Mhm.
It's you know that whatever you're going to imagine it's going to be, you're going to be wrong. But what do you think your job's going to look like in 10 years?
Well, one thing we're already doing differently is we're starting oral immunotherapy almost at the time of diagnosis, and for families who are interested, so in infants and toddlers. We used to avoid giving oral immunotherapy to those younger children because we were afraid it was going to cause adverse effects and they weren't able to speak and things like that. And now we're learning with more and more evidence that, well, perhaps if we start it during this window of opportunity, we might actually cure these kids. Whereas it's very unlikely you're going to cure an adolescent. They already have established food allergy. We can desensitize and protect them. So I think we're going to be doing a lot of these therapies early. And not waiting for them to have develop long-standing, food allergy and things like that. So that's exciting. And then just the ongoing milieu of options. We may have epicutaneous immunotherapy or the peanut patch, which a lot of people have heard about for years and years and years. Like the data look great. There's no reason
Yeah,
why we shouldn't have this. It's very safe, and that's going to be a great option as well. What I'm really excited about are oral BTK inhibitors,
yeah,
because that potentially we could even use this like more like on demand. Like if you're going to go away for summer camp, we could potentially start this, assuming that it pans out and it works well. This treat for a couple of weeks, or if you're going to go traveling or something like that. So it's so exciting. But yeah, 10 years from now, if you and I are still doing this, then I don't know. I guess the curse is real and the passion remains with us.
absolutely. Yeah. No, well, look, I mean, there's lots to look forward to, and I'm fascinated to know how you guys have got on with Neffy, because it's again, huge amount of talk about it. We are still we'll probably get it in the UK towards the end of the year.
Mhm.
But in a way, I like the idea that you guys get it first, and we get to learn from your experiences, and then we can sort of save having to learn the hard way ourselves. How's it fit? I think there was this initial idea that it would be some sort of wholesale moving across, and I have to say the first person I told about it was my niece, and who carries EpiPens, and I'd sort of said to her, all being well next year, we'll be able to. There'll be this device that you'll squirt up your nose, and you won't have to. And she immediately said, "I'm stealing anything out my nose. I'd rather use an EpiPen." And it suddenly dawned on me that, oh, okay, maybe it won't be the panacea for everyone. And of course, looking at data, that there's going to be a lot of people who'll feel, what, I just want to carry both because I'll probably use one sooner, but I still want to know I've got the one that work, that may work quicker. How are things working?
Yeah, so it's getting more and more insurance coverage as time goes by, which is great. And they also have a specialty pharmacy that will give two devices for $199, which, in comparison to some of the auto injectors, is actually less expensive. Plus, they last for 2.5 years compared to a
Yeah.
12 to 18-month expiration. It's interesting. Some people say, yes, absolutely, we want this. Others say, no, it's too new, or, how do we know it's going to work, that sort of thing. Or others say, I don't mind the needle. I'd rather do that than shove something up my nose. So, but it's great to have an option to discuss with people.
Yeah. And how about in your clinics? Are you sticking with intramuscular or moving across?
Well, we're trying to get it on formulary right now, actually, which has been
Okay.
a bit of a battle, just trying to explain how it's different. What we'd love to do in the U.S. is there's various sites we want to actually start using this during like a trial during food challenges. So randomize people and then compare, efficacy, time to resolution of symptoms, adverse effects, that sort of thing. Because, it's really hard to study these different products no IRB in the world is going to allow somebody to design a study where we induce anaphylaxis and then see if an experimental treatment works or not. So we have to do it post marketing and once it's available. So yeah, I think we're going to learn a lot more in the next couple of years.
And do you think Anafilm will change things a lot? What are the timings of their pipeline? Do you know?
I do, yeah. So they're hopefully will be approved by the FDA in the early part of 2026. And they're interesting. So all of these, manufacturers, they use the pharmacokinetic and pharmacodynamic data to get approval. So you take healthy volunteers and you measure how fast does the epinephrine peak in their bloodstream, what impact does it have on heart rate and blood pressure and things like that. And they all look pretty comparable. And then the sublingual epinephrine also had people with oral allergy syndrome who ate their food and had acute symptoms, and then they used it to treat their symptoms. And their time to resolution was ridiculously fast, like on the manner of like minutes.
Right.
So yeah, it's pretty cool. So they took the next step to actually treat people having acute symptoms. Now, was it anaphylaxis? No. So we have to see what that looks like. But yeah, I think again, it'd be great to have options. Coverage always matters. If it's going to cost $1,000, nobody's gonna use it. So we have to figure that
Yeah.
part out as well.
It's like the buses in London. Nothing happens for years, and then two come along at once.
And there's another nasal
Yeah.
spray as well in development. So we're going to have options galore.
Yeah. No. Fantastic. So, look, you've been hugely generous with your time. Thank you. There's a lot more I'd love to have talked about, but we're coming to the end of our time. So a big thank you, and maybe in the not too distant future we can do this again.
Yeah, that'd be wonderful. Thank you so much for inviting me. It's been wonderful speaking with you, and I hope to see you again soon.
Thank you.